Guys, I've got 12 on mine. We'll get started. Welcome everybody to Idaho MGMA's education series. We are going to be focusing today on some upcoming changes that are actually pretty significant coming up in 2021, all regarding the, as you can see, the title of Amy's presentation, the evolution of the E&M codes. We have some pretty significant coding changes coming up, and it's good to, a few months out, prepare for that. I would like to take a quick moment to thank Medigold. They are our 2020 education series sponsor. So not only are they sponsoring today's luncheon, but they're actually sponsoring every single monthly webinar that we're putting on. So thank you to Medigold. We, as you're coming in, you'll notice that you're all muted. I had a Zoom meeting today where I did not have that in place and had too many people, and they kept talking, and it finally got to the point where I got grumpy enough just to hit end all, and I ended the meeting. But that is not how we're running it today. We are much more organized. If you do have the ability to unmute yourself. If you click on the microphone icon next to your name under the attendee list, or at the bottom of your left-hand side of your screen, you can unmute. However, but for questions, if you have them during the presentation, you know, use the chat function there on the side. It's on you can access it through the toolbar at the bottom of your screen, clicking on the chat bubble icon. Send them out to everyone so that our presenters can see them. Shelby and I will be looking at them and keeping track of them and trying to help Amy as she's speaking. At the end, if we want to unmute and ask a few verbal questions, we can do that as well. If you wouldn't mind taking a moment, we like to take attendance here on our IMGMA webinars. So if you could change your name to your first and last name so we can do that. You do that by clicking on the participants button down at the bottom and clicking the 3 dots next to your name, and then you can actually change your name. You can click change my name on there and actually type it in. I wanted to take a moment, just a quick moment, to talk about the ACMPE or the CMPE certification. Just a very quick thing. While I was looking and doing some benchmarking for staffing the salaries for our practice and for a couple others, I got curious and I looked at the administrator pay, and I did a comparison between somebody who is not certified with their CMPE and somebody who is, and on average, those with the Certified Medical Practice Executive certification, those letters behind their name, make $17,000 more a year than their counterparts. And I'm not saying that you go and you take the quiz, the exams and get your credits and get your CMPE, and all of a sudden your boss is going to throw 17,000 large ones at you. But the difference in the career paths is quite significant. This is just one aspect. You know, having your certification helps you be a more well-rounded and effective leader and manager. It can help as you're looking for that next position or trying to make your way through your career. But this is just one aspect of it. Financially, CMP certificates just make a little bit more money. So just kind of putting that out there. If you guys have questions about the CMPE, if you are just curious about it, you can email myself or Matthew Godfrey, who is actually our CMPE representative on the IMGMA board. Shelby, if you wouldn't mind, would you put mine and Matthew's emails into the text thread for everyone? And maybe that'll even just kick off the thread that you can type questions into as well. But yeah, take those emails, reach out anytime. It's super informal to do it. You know, you don't feel any pressure. But yeah, any question, feel free to reach out. A couple of announcements that I have for the end of the meeting that I'll just put out now, just in case a few people hop off. From here through the end of 2019, we have decided as a board to continue to do these virtual educations throughout the rest of the year. We're not going to be doing any in-person ones. If any of you know me, you know that kills my soul to not have some sort of social aspect to these and be able to see people in person. I love coming to the luncheon meetings and of course the conference and being around all of my friends, IMGMA friends, but you know, just for safety reasons and being able to plan, this is just how we're going to roll for the rest of the year. That does mean, and I hope the rest of you either heard the announcement in the last meeting or got my my letter to the general membership, but we are canceling our annual conference this year. We are going to be working on providing additional value, and we're trying to do so without any additional cost to the membership. Trying to find sponsors for certain boot camps, trying to put together virtual roundtables or peer forums, trying to find a couple keynote speakers that we could bring in. So we're working on all of these things in the meantime to try and make sure that we're supporting you guys as we're, you know, I don't know about you, but this is probably one of my toughest years in my career, with just everything flying at us. We want to make sure that we're here for you. If you have any ideas or questions or concerns about what IMGMA should be doing to help you, please reach out either to the Idaho MGMA at idmed.org email. You can find that on our website, or Shelby, if you wouldn't mind throwing that email in there as well, or reach out to myself, and I can make sure to direct it to the right place. Oh, okay. I think those are all of my announcements. So I will take a second to introduce Amy Bailey, and we'll move into our presentation. Amy is actually the principal of HBE Advisors and has 20 years of healthcare experience and specializes in a couple of things: regulatory compliance for coding and billing, with emphasis in documentation, coding and billing reviews, due diligence and risk assessment reviews, internal investigations, and litigation support services. Amy has extensive experience working with publicly traded healthcare companies, large hospital firms, law firms, large hospital systems, law firms, and physician group practices. Amy's experience ranges from handling routine and compliance issues to provider defense of government false claims and fraudulent coding and billing cases. So kind of a really wide spectrum there. Amy is certified in healthcare compliance and is also a certified coder for both physician and hospital coding, and an improved coding instructor for the American Academy of Professional Coders. Amy, everybody's on mute, but I'm just a big welcome from all of us, and just an appreciation for you being here today to educate us on the big changes coming out for our E&M codes. So I'll turn the time over to you, Amy.
Okay, great. And then Jesse, just so you know, I've got the chat box minimized so I can see my screen. So if somebody pops up with a specific question about a slide, if you just want to interrupt me and ask, I'll be happy to answer. And then of course there'll be a little bit of time at the end where I will certainly take any additional questions that if anyone has any.
Absolutely, Shelby, and I'll watch that. Thank you.
Okay, perfect. Thank you. So let's go here. So today we're talking about the E&M changes that are scheduled to be implemented in January. We're just going to go through a little bit of the back. We're going to touch on the requirements that are going to be in place starting in January, and I will try to go through and pinpoint the things that I think are probably the most significant changes. We'll talk about implementation strategies, and then we will talk about some auditing and monitoring recommendations. So we'll start with the background. CMS first rolled out these, what I'm going to call really sweeping changes to physician evaluation and management coding back in the 2019 proposed fee schedule. And then the bulk of what they proposed did become final in that 2019 final fee schedule. In this year's proposed and final fee schedule, they added some additional provisions, took some of the initial proposed rules away, and now we're sitting with what we think January will look like. The 2021 proposed fee schedule, from what I understand, should be released next week. I would suggest that everyone take a look at that. I would anticipate there will probably be some additional changes, revisions, or proposals surrounding this E&M redo in that. So I think while foundationally probably everything we talk about today in a large part will be what we see in January, but it is possible that there will be some changes to what we're talking about and that'll be released within the next week or so. So just keep that in mind. You know, these changes really came primarily and were really motivated primarily from, you know, physician group organizations complaining about the E&M guidelines that we have right now. Physicians are really concerned that they are clinically outdated, that they really aren't meaningful to them as clinicians. And the guidelines, since they're universal and apply across the board, that they really don't account for the differences in individual patient complexity or complexity across various types of provider specialties. The other line of thought in justifying why we're having this change in the guidelines is that both CMS and a large number of enforcement agencies, the OIG, the Department of Justice, your RACs, all of them have issued, you know, audit report after audit report and fraud alerts concerning electronic health records and the volume of documentation that is contained within them, and being concerned that providers are coding based on that volume of documentation. And there are a lot of concerns about upcoding and improper reimbursement from that perspective. CMS has stated that they believe that the documentation has proliferated in a way to support the various documentation guidelines, to where now we have medical records that contain a lot of extraneous information that isn't pertinent to the patient, isn't pertinent to the healthcare providers, and that is actually preventing patient care and really inhibiting providers from pinpointing what's most important to them to provide patient care. The AMA really agreed with CMS and the physician community on these statements. They talked about note bloat, which they think really stems from the whole template and checkbox mentality that we have right now, which is really needed to meet the current documentation guidelines. So the AMA, working with CMS, said, yeah, let's make some changes. So the AMA has published a number of additional changes that will be coming out in CPT so that they align and mirror what CMS has laid out in terms of the documentation guidelines. Again, all of this is going to be effective in January, so just 6 months from now. And I have been told from a number of individuals that are working in DC in lobbying varying positions that we aren't expecting any implementation delays. January 1 is going to be the go day. For those of you that aren't currently aware, CMS during the public health emergency that we're experiencing right now is allowing providers that are performing telehealth visits to code those visits based on time or medical decision making. So we can ignore the history and exam and really use the guidelines, the 2021 guidelines, if you will, right now until the end of the public health emergency. So the AMA has laid out what their primary objectives are for these new guidelines. Their goal is really to decrease the burden on your providers for having to document unnecessary elements in the medical record. The AMA has said that they want to decrease the need for audits through the addition and expansion of their definitions and guidelines. I don't think that's going to happen. I think CMS has already fired the warning shots that that is not going to happen. And we'll talk about the auditing a little bit later and why I think it's going to be even more important as we transition. The AMA wants to, again, decrease unnecessary documentation in the medical record that isn't needed for patient care. And they want to make sure that the payment for E&M services going forward is more resource-based. So let's talk, are there any questions at this point that I need to address?
Nope, you're good, Amy. Go ahead.
Okay, perfect. Okay, so let's talk a little bit about what are the guidelines going to look like next year. They're going to be very, very, very different. But the one thing I want to point out and stress as we go through this is that everything that I'm about to talk about applies only to outpatient office. So if you have providers that see patients in the hospital setting, in a skilled nursing care facility setting, or any other setting other than the outpatient office, these rules don't apply. So just keep that in mind as we go forward. At the high level, in CPT, in your CPT book, the instructions for E&M selection are going to be completely revised. History and exam are no longer going to be one of the contributing factors to code selection. All of your coding for outpatient office E&M is going to be based either on the documented medical decision making or the total time spent. And we'll talk about what the instructions are for each of those things because they've changed a lot. CPT 99201 is deleted starting in January. And then there's going to be new prolonged service codes for outpatient office. So history and exam, there are some substantial changes with respect to documentation of these areas under the new guidelines. So The documented volume of history and exam are not a component of code selection for outpatient office next year. So we're not going to care if the physician documented a comprehensive history and a comprehensive exam. We're not going to be picking codes based off of that or looking at that. What the requirement will be from both the AMA from a CPT perspective and from a Medicare perspective, because remember their guidelines mirror each other now, or they will. The provider needs to document a medically appropriate history and physical exam. The extent of that medically appropriate history and exam will be determined by the treating physician or treating provider. The healthcare, their care team, so their nurses and assistants may collect information. So they can do the collection of the patient history, vital signs, all of that, or the patient may provide that information, or the caregiver may provide that information, and then the actual provider just needs to review it. So those are the changes for history and exam. We've got some big changes with respect to coding an encounter based on time. So under 2021, time may be used as the sole criteria for code selection for your 99202 through 205, 99212 through 215. The requirement that we have right now that says if we want a code based on time, the documentation must reflect that more than 50% of the face-to-face encounter was spent counseling and coordinating care. That will no longer apply. That requirement's going to go away in 2021. And instead, what we will expect is that the provider document the total time that they have spent on the day of the encounter. And that can include both the face-to-face time with the patient and the non-face-to-face time that was personally spent by either the physician or your nurse practitioner or your physician assistant. And it's the time that they spend, and we're going to call it performing qualified activities, and I have those listed on the next slide so that we can go through that. What the time you may not count is time that would normally be spent by your clinical staff. It has to be time spent by your billing provider. And so what counts towards that total time on your day of encounter? That can include the time that your physician or NP spends preparing to see the patient. So if they're reviewing old records, they're reviewing test results, they get to count that. Obtaining or reviewing history that was given by someone other than them. Performing their physical exam, providing counseling or education to the patient, family, caregiver, time they spend ordering medications or tests or procedures, time they spend communicating with other healthcare professionals, time they spend documenting in the medical record, care coordination, all of that. So basically everything that goes in to them providing a patient encounter is considered part of that E&M time, with one exception. Services that are separately billed, the time spent doing those has to be carved out. So as an example, if you have a provider that is interpreting an X-ray and interpreting an EKG, as part of their E&M visit, the time that they spent interpreting those diagnostic tests may not be counted towards their E&M time if they're going to separately bill for those interpretations. Okay. Medical decision making. This also has an extraordinary number of changes. I think the changes with respect to how we evaluate medical decision making will be really, really well received by your providers. There are going to be changes that some coders and auditors really struggle with. So we'll talk about that. What is included in the medical decision making is really the same as it has always been. We're going to be considering the number and complexity of problems that are addressed during any given encounter. And we're going to be looking at the amount or complexity of data that has to be reviewed and analyzed during any patient encounter. Data.
Hey, Amy, we have a question come through real quick.
Yeah.
Raquel asked, what about the time spent on the day before the patient is seen, which includes reviewing data, et cetera, for that day?
Yeah, the rules are specifically written as of today that the time has to be spent on the day of the encounter. So as the rule is written today, time spent either the day before or the day after would not be counted. Okay, back to medical decision making. So there are some new definitions where the AMA is defining some of these things, and we'll get into them a little bit more. But they have three categories of data, if you will, that we will be evaluating in order to determine the level of medical decision making for each encounter. So that can include the provider reviewing tests, various documentation in the medical record, ordering services, obtaining information from independent historians, a wide range there. And then we're still going to be looking at the overall risk of complications, comorbidities, comortalities with respect to the conditions that are managed at each encounter. One of the changes, this first bullet point that I know physicians are absolutely going to love, the AMA came out and specifically said that for the final diagnosis, we shouldn't be looking at that and saying, well, based on the final diagnosis, that condition does not in and of itself determine the overall complexity or risk of a particular patient, because they recognize, at least in the new guidelines, that an extensive evaluation may be required to reach a determination of what that diagnosis is. And so what's historically happened, and I know I've encountered this a million times with doing audits and talking with different auditors and coders, is a patient will come in, they're presenting with severe chest pain. The physician, of course, is going to do a very extensive evaluation of that patient to ensure that that chest pain is or is not cardiac in nature. And sometimes what we'll see is they do a very extensive evaluation and they determine that the patient has some type of gastrointestinal diagnosis. Heartburn is an example. And what we will see a lot of times, and it's really frustrating to physicians, is that the coders will down code those encounters based on that final diagnosis. And they will say, oh, well, the patient only had heartburn. Well, the physician didn't know that coming in. So they did a lot of work. They want credit for all of the work that they had to do, regardless of what that final diagnosis is. And the AMA has really come out in support of that and saying you can't just look at that in isolation. They've also pointed out that you may have multiple problems of a lower severity, where maybe you have the patient comes in, they have three pretty simple problems, but in aggregate, because they have multiple problems, the risk is increasing, and the AMA wants to recognize that when a patient has multiple conditions, that can increase the complexity, even though individually they may not be that big of a deal. They also laid out some guidelines that are a little more consistent with ICD-10 coding rules as well. So they have said, you know, a patient may come in with 3 or 4 different symptoms, but if they all pertain to a specific diagnosis, we may not really treat them separately for purposes of scoring out medical decision-making or evaluating medical decision-making. We may treat them all as one based on that definitive diagnosis. They also say that even though the patient may have the presence of other conditions or other diseases, that those should not be considered towards your level of evaluation and management service unless they are individually addressed and managed during that encounter. The new CPT book has a number of revised guidelines for that contain not only how you use the new criteria, but they also provide a number of definitions that are really helpful. So they define things now like what is a self-limited or minor problem, or what is an acute illness with systemic symptoms, to help non-clinicians, if I will, kind of better categorize those presenting problems that you're evaluating for purposes of E&M coding. So we'll take a look. I've provided what the 2021 definitions are for each of these categories and provided the clinical examples that the AMA has provided. There is one particular change in here that is a pretty big departure from our current guidelines that I want to point out to everyone. And that's with respect to how a stable condition is going to be defined starting next year. So starting next year, the AMA CPT defines stable problem is one that where the specific treatment goals for that individual patient are met. They specifically say that a patient that is not at their treatment goal is not stable, even if the condition hasn't changed and there is no short-term threat to life or function. That's a pretty big change from the coding criteria right now. So I just want to point that out to you. I think the other definitions are pretty consistent with what we have right now, but that one's a big change. Just to give you some examples of what the medical decision-making criteria look like going forward to next year. There's a couple of really big changes that I want to point out. we're still considering the number and complexity of problems that are being addressed. That's relatively consistent from what we have now. The big change is really in the section of the amount and or complexity of data to be reviewed or analyzed. Right now, when we're looking at that under the current criteria, if a physician orders lab, they get criteria for ordering a lab, regardless of whether they order 3 distinct lab tests or 10 distinct lab tests. They just get credit, you ordered a lab. Doesn't matter how many. Under the criteria starting in January, each individual test or order, you get credit for that. So when we're looking, as an example, at a 99213, you must meet the requirements of at least one of the 2 categories. So we have category 1, which is you've ordered tests and reviewed documents, or category number 2, you've done an assessment that required an independent historian. I think a lot of providers will probably be looking at the category 1. What types of tests did we order and what types of documents did we review? The criteria says that you have to meet any combination of 2 from the following. Review of the result of each unique test. What you get credit, this is where how many tests you order comes into play. So if the physician ordered a lab and a x-ray, they've met this criteria. If they've ordered 2 laboratory tests, they meet this criteria. So that's where the counting of the tests that are ordered, which is different for this coming year, is really going to come into play in terms of how we evaluate medical decision making. And I've given it to you for each of the levels just so you have it. I'm not going to spend time reading through these to you. I don't think that's a good use of our time. The actual structure, like we talked about for 2021 and how we pick our codes, these are the criteria for each of our levels of service in 2021. So 99202, now you can see the criteria is just a medically appropriate history and exam and straightforward medical decision making. The times are different than what we have right now. When we look in CPT right now, we have every level of services associated with an average time. In 2021, that average has been removed and we have an actual time range, and it is explicitly specified as the minimum time spent. So there's no average. If you want to code a 99203 based on the time spent, that provider will have to have spent a minimum of 30 minutes with that patient or providing patient care or activities related to providing patient care on that day. For prolonged services, those are going to be a little bit of a change. There's a new code and we'll talk about that in just a minute. You only are able to report prolonged services once you have exceeded the time threshold for your level 5s with whichever category is appropriate, a level 5 new patient or a level 5 established patient. So the established patient criteria are here, same thing, it outlines, you know, what the documentation requirements are in terms of a medically appropriate history and exam and what level of medical decision making is required. And then, like I said, the times are different. So that's something you're really going to want to pay attention to as you start setting things up for providers for this upcoming year. Because I know a lot of providers are accustomed to documenting time under the current rules. So they're used to knowing that a 99213 is associated with an average of 15 minutes. But under 2021, a 99213 now you have to have spent a minimum of 20 minutes. So there's some differences here that where your providers are going to need some education and your coders are going to need some education. I mentioned that there are changes for the prolonged services. The current prolonged service codes, the 99354 and 5, and the 99358 and 99359 are no longer going to be reported with your outpatient office E&M codes. You can still use those codes for different place of service encounters, but not for the office. There will be a new code that you will use with the for prolonged services with your outpatient office E&M codes. I've put it here. Same as it has always been, this will be an add-on code that you will add on only to your level 5 services if the time thresholds are met. And kind of same with everything else that we've discussed with E&M, any time that is spent rendering separately billable services would not be counted or reported here. And then I gave you just a breakdown. This is coming right from the final physician fee schedule. They've provided some tables for you so that you have your time thresholds with how the billing should look and the billing units. And I gave that to you for the new patients and also the established patients. Finally, CMS addressed the concerns from the provider community regarding the different types of resources that are utilized in rendering E&M services. And this commentary really stemmed from your kind of specialty providers, your cardiology providers, your neurosurgery providers, some of those more complex specialties who really felt like the services that they are rendering during an evaluation and management encounter were more intense or more complicated than maybe a family practice provider encounter. CMS did agree with them, and they generated a new HCPCS code that is also an add-on code. It can be reported with any level of outpatient office E&M. It says it is to report visit complexity for providers that have patients with serious medical conditions, complex chronic conditions, and they're providing the management for that. They will be able to, at least for Medicare, report this add-on code in addition to their E&M, and they will receive additional reimbursement for it. In terms of reimbursement, based on the current RVUs and the RVUs that were finalized in the 2020 physician fee schedule, I think by and large, there are increases in the RVUs. So we should be seeing some increased reimbursement next year for most providers under these new guidelines. So implementation strategies, there's a lot to think about. We only have 6 months until these changes are effective. And I think for most providers, it is going to be an operational nightmare. If you haven't already, I would strongly encourage you to form a work group or a committee that includes compliance, HIM, coding, quality, IT, and ideally a physician champion. I think you're going to need to start evaluating the changes that will be required, one, within your electronic health record, so that you can allow your providers to start documenting in accordance with the new guidelines as well as the old guidelines, or the guidelines that are current right this minute. If you have a system where you rely on system generated or automated generated E&M coding, you're going to need to start thinking about testing that coding utilizing the new guidelines and make sure, if there are changes that need to be made in terms of programming so that you're generating the correct codes, now's the time to start looking at that. And the thing to keep in mind, and why we really need to be focusing on this, is that these changes are going to require most providers, coders, auditors to operate daily under two significantly different sets of E&M and documentation guidelines. So if you have, like a lot of providers do, you have providers that see the patient in the office and also see patients in the hospital. You're going to have two sets of E&M criteria that you're trying to balance and two sets of documentation guidelines that you're trying to balance. Hence why I think this is going to be an operational nightmare for most. So the types of things you can think about, what types of alerts from a system perspective can you put into place to make sure that you're using the right guidelines for documenting and coding based on the place of service? And what types of edits can be implemented to alert you if you have separately reportable services on the same day as an E&M? How do you make sure that those separately reportable services weren't utilized for purposes of determining your medical decision-making or your total visit time? Because remember, those have to be carved out. If you haven't, you definitely need to start providing regular education to all of your coders, auditors, and clinical staff about these changes. Documenting and coding in a test environment using the new guidelines is going to be critical. I think you're going to need to really objectively evaluate what type of additional training are your coders and auditors going to require in order to accurately be able to evaluate medical decision making. I can tell you, under the current rules, it's an area where coders and auditors have historically struggled a lot, and the bulk of the disagreements in coding between physicians and coders kind of center around this particular area. With coding going to be based largely in part on medical decision making starting in January, your coders are going to need a lot of help and support in that area so that they feel comfortable with evaluating that, that component. I would use your test cases to project changes in provider and coder productivity. I would also use them to estimate changes in E&M utilization and then reimbursement. You need to take a look at your policies and procedures to make sure that they are updated and promote compliance with these new requirements. And you're also going to want to take a look at what type of documentation requirements are mandated by your liability insurers because going forward under 2021, the requirement from CMS and from the AMA is that you only need to document a medically appropriate history and exam. Your malpractice insurer may require that the physician always document a comprehensive history and exam. So that's going to be something you need to take into consideration. Okay, auditing and monitoring. Once we get over this hump and into the new year, even though the AMA said, you know, one of their goals is to reduce the burden of auditing and monitoring, you know, this type of change is really going to initiate some new compliance risks. You know, anytime you're operating under 2 sets of E&M guidelines, it's going to really guarantee that you're going to have quite a few errors. So I don't think that the need for auditing and monitoring is going to be less. CMS, from their perspective, already said in the 2020 final fee schedule that they have concerns with these changes that are going to be implemented about potential shifts in the visit levels, and that they fully intend to monitor claims data. One of the things that not only CMS, but your private payers like your Blue Crosses, Blue Shields have always done is they utilize data analytics to identify potentially problematic providers or identify aberrant coding patterns. And one of the elements that they use when they're doing their data analytics is looking at the equivalent of time that providers are billing on any given data service. So when we're moving to an environment of coding based on time, you know, we've got some concerns if providers keep their current volumes and now all of a sudden they shift to coding everything based on time. There's the potential to really kind of over-report or report the equivalent in hours of more services than you could have possibly provided. And what I mean by that is, you know, depending on what level of E&M code they assign, the number of visits that is reasonable for them to perform on any given day is going to vary widely. And so kind of what you would get is a normal payer analysis. If we have a normal day by a provider, we'll say they have a mixture of established patient office visits with a few new patient visits thrown in, and they see 30 patients in one day, which I think we have some providers that see a little bit less than that. We have providers that see more than that. This would be a pretty typical E&M distribution that we would be accustomed to seeing when we're auditing a provider. The bulk of them, we'll say the provider reported at a level 3. We've got some level 4s, just a small handful of level 5s, and then just a few new patients thrown in there. If we take those volumes and then multiply them by the minimum time that the AMA says that you have to have spent in order to code based on time, that particular CPT code based on time, and we multiply that out, we're now taking what a normal historically provider distribution for one day is, and we're saying now that he spent 15 hours in the office seeing patients on one day. And that's what you're reporting to the payer. I can tell you from my experience, it doesn't take reporting very many days that look like that to a payer for them to initiate an audit. So that's going to have to be something that you monitor very closely going forward, is the time equivalent of hours that you're representing have been spent. Codes selected on the basis of medical decision-making will also obviously need to be reviewed for reasonableness. You want to make sure that the medical decision-making was assigned consistent with your new risk category definitions. Again, we want to make sure that we're not considering separately billable services. We want to make sure that we're not considering conditions that were not evaluated or treated at that encounter. You want to make sure, because I know providers still love their templates, that the documentation of your encounters is unique from patient to patient and visit to visit. What we don't want to see under these new criteria is that every visit looks substantially the same, where we have a template history, a template exam, and then just a statement that says, I spent 15 minutes performing this encounter, reviewing medical records, examining the patient, and discussing the patient's treatment options for every single patient. That is going to be a problem. And if you were to get audited, that's not going to go well from a payer perspective. You know, again, your auditors and coders are going to have substantial clinical knowledge. They're going to need to be really careful to make sure that they're applying the right set of guidelines depending on the place of service. And then you should be trending pretty carefully starting towards the end of January. You should be trending your new coding patterns and comparing them to your historical data. The one thing we wouldn't expect to see and should not see under the new criteria is all of a sudden every visit you have is a level 4 or level 5. That should trigger to you that there's a problem. So that was fast. I know we're close on time, so if anyone has questions, I would love to answer them. I gave you the link to the AMA where it contains all of the revised guidelines that have been published at this point. I have given you the link at least to the 2020 final physician fee schedule. And as I said, the 2021 proposed should be out next week. And if you have follow-up questions, if you get done today and you think, oh, I have a question and I didn't ask it, you can feel free to reach out to me. My email address is here and my phone number is here.
Amy, it looks like we have a question in the chat box. It says, much of the quote-unquote bloat is all unrelated to care documentation for MIPS. How would you handle this?
I don't know. They haven't really addressed what they want to do about MIPS under these new criteria and the note bloat. So I was hoping, and that's one of the reasons why I wanted to see the proposed schedule. It was, I have been advised that that question has been raised and that there should be some guidance coming on how to marry that with the new criteria.
Okay, thank you, Amy. Are there any other questions? Feel free, guys, to unmute yourselves if you'd like, or you can type them into the chat function. We have a minute or two if you'd like. Otherwise, I'm sure if you have additional questions, you can take my email from the chat box or Shelby's with the general info one for IMGMA, and we can forward questions on to Amy as well. Last chance, I'll give you guys a quiet 10 seconds if you want to unmute and ask questions. I do see a question from Lori asking me where we can locate the handouts. Shelby, on our web, can you maybe give the specific cookie crumb or breadcrumbs to where it's going to be located on our website?
Sure. So just an FYI, we'll probably send out a link in a follow-up email that we usually send the survey with. So you'll get a direct link to where we're going to put it. But just in the future, if you're ever looking for what these webinars, if you go to our main website, there's a taskbar at the top. It's just called webinar recordings. And then we have been adding this summer, since COVID, we've been making them free for members and non-members. So same with this one. This one will be posted there along with the slides. And then once we go back in August to our regular schedule of charging non-members, they will go into a section on our website for members. So members can still access them on the back end if you're logged in. And then if you're a non-member, you can pay I think it's $20 a webinar to access that. So it's just called webinar recordings, like I said, at the top of our website there. And then we will send a link via email to everyone who's registered that gets a direct link to this page.
Awesome. Great. Okay, guys, I don't see any other questions in there. Last chance to interrupt me. Going once, going twice. I think we are good for today. A huge thank you, Amy, for all of that information. We're super grateful for it. Incredibly helpful. This is something that we're going to have to be watching for the rest of the year and all the way through probably 2021 as we get used to it. So thanks again. Also, again, a thank you to MetaGold for helping make this event possible. A reminder that all of our educational series are going to be virtual through the rest of the year. Our next one being Thursday, August 13th at 12 p.m. You guys are going to get an email following the event with a link to the materials and the recording, but also to the post-event survey. Those are super easy to fill out. They're quick, but very helpful on our end to know whether or not these things that we're doing are on the money or need a little bit of change. So please fill that out. And that's it. Thank you guys just for being awesome active members of Idaho MGMA, and we'll talk to you all soon.
Thank you so much, Amy. We really appreciate your help. I think it's going to be super valuable for our members for sure.
Yeah, thank you, Amy.
Sure, thank you, my pleasure.
Bye, Shelby. Take care.
Bye.